So this is a joint joint webinar on recent changes to Medicare coding, and it is co-sponsored by the New York chapter of the American College of Physicians and MAGS, which is the Metropolitan Area Geriatric Society. Go ahead. So the disclosure: no one on the planners for this educational activity have any relevant financial relationships to disclose. Dr. Zorowitz has no relevant financial relationships to disclose. Just to tell you a little bit about Dr. Zorowitz, for those of you who don't know him, I guarantee you've read something that he wrote, you just don't realize it. He's the regional vice president of Health Services Humana. He's a graduate of Albany Medical College. He's board certified in internal medicine, geriatrics, and palliative care. He's a CMD in post-acute and long-term care, and he's the American Geriatric Society advisor to the American Medical Association CPT editorial panel. So he literally knows what he's talking about. To share with you a little bit, because I know we have people from both NYACP and from MAGS, and some people who are not a member of either. NYACP is the New York chapter of the American College of Physicians. It's the largest medical society specialty organization in New York State. It advances the specialty of internal medicine and its subspecialties through education, advocacy, and quality improvement. They represent over 12,000 internal medicine physicians. I am the chair of the Geriatrics Task Force and the governor-elect designee for the Long Island region of the NYACP, which means starting, I think, a month from now, I become the governor-elect. And so I also want to share with you, there's some upcoming NYACP events. March 13th is a Coalition to End Racism in Clinical Algorithms. March 19th is the second part of our Elder Abuse series. March 22nd, and then 2 more dates are the Women in Medicine series. So please check out the NYACP webpage to find out more. NYACP invites you to put on your calendar. The annual education meeting is going to be in Tarrytown in October, and they are collecting abstracts as well as teams being formed for the Doctor's Dilemma competition. So check that out. I want to take this moment to introduce to you Philip Solomon, who will speak to you about MAGS.
Thanks, Paula. So I'm Phil Solomon. I'm a geriatrician at Northwell Health, and I'm the current president of the Metropolitan Area Geriatric Society. So for those people in attendance that don't know about MAGS, it was first founded in 1986. It serves the New York City, Long Island, and Westchester metropolitan areas. So MAGS is the New York regional affiliate of the American Geriatric Society, and our mission works to foster interprofessional collaboration between geriatrics providers, educate providers on recent advances in the care for older adults, and also to advocate for improvement in public policy and healthcare that impacts older adults. We typically have about 5 events per year. So we're obviously excited to be co-hosting with the NYACP for this event tonight. And for those people who are not part of MAGS, we encourage you to check out our annual Geriatrics Fellows Research Night on May 22nd on Zoom. So a great opportunity to see some of the local scholarship that's being done by trainees in the New York metropolitan area. So at the end of tonight's event, you'll be able to get CME credit. You'll have a link that's sent to you and be able to fill it out. It doesn't matter if you are a member of NYACP or not. You'll be able to go through and submit this for your credit. And if you have a minute, scan this code. We'd love to get your feedback on this event. It really helps us to craft events moving forward, especially for joint events like this between 2 of our organizations. So with that, I'm going to hand it over to Dr. Zorowitz. And if anyone has questions during the lecture, please just drop them in the chat, and we will try and get to them at the end of the hour.
Okay, thank you. And I might point out that MAGS was established in 1986, and I was at those first meetings and came for a number of years. And I really should start coming back again. Okay, we got a lot of material to get through tonight, and I'm going to try. I may be going pretty fast because there have been a lot of changes this year. I hope for the better. These are my speaker disclosures. I am an employee and stockholder of Humana, but I have no financial relevant financial and conflict of interest to disclose, and these opinions are mine and not Humana's. And I want to thank the American Geriatric Society for allowing me to steal much of the content in these slides. These are our objectives, and you can see this is a pretty robust list. I'm not even going to read it to you because I want to get right into stuff. I want to remind you, I'm not going to go into the basics of choosing a level of care for E&M services, but I do want to remind you that we have the option for E&M services of using total time or the level of medical decision-making. And sometimes the level of medical decision-making will yield a higher reimbursement than time. So I just want to remind everybody that there is a benefit to learning the medical decision-making. This is it. I'm not going to go over it, as I said, but I do want to remind you that if you want to learn medical decision-making, it is described entirely in the 2024 CPT manual. I highly recommend that you have a copy of that. Okay, we're going to get to this code, which I think is probably on everybody's mind. It's the Office Outpatient Visit Complexity Add-on Code G2211. So let's get started. This became effective January 1st of this year. CMS decided to reimburse it. This was created by CMS. So when CMS creates a code, it usually has a letter like a G in front of it versus CPT, which are those typical 5-digit codes. Now, this particular code reflects the complexity associated with comprehensive primary care or ongoing medical care of a patient with a single serious or complex condition. This is what's really important. It may be reported only as an add-on with office outpatient codes 99202 to 99215. Cannot be reported for home visits, can't be reported in the nursing home. Only 99202, 99215 is an add-on. And the reimbursement is about $16 in addition to the reimbursement you would get for the accompanying office outpatient E&M code. So whenever I say office outpatient E&M code, I'm referring to 99202 to 99215. This is the code descriptor from CMS. Visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services, that's all needed healthcare services, and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. In parentheses, add-on code lists separately in addition to the office outpatient evaluation and management visit, whether new or established. So, per CMS, the patient-clinician relationship determines the code's use, not the specific clinical condition being treated in the visit. If you are a primary care physician and you are the focal point for all continuing needs for this patient, then you are entitled to use this code. It may be used for ongoing care of a patient with a single serious or complex condition. We'll get into an example in a little while. The level of the E&M code at any given visit doesn't matter. And it can be also reported when the patient has an office outpatient visit on the same day of visit or a procedure performed by another clinician. And I should also mention there are no frequency limitations. CMS will be monitoring. CMS doesn't expect it to be used for every single visit, but they don't have any frequency limitations on it. So for instance, if you're seeing a patient every month, every 3 months, theoretically, if every visit meets this requirement, you can use it on all those visits. Now, there are some exceptions and some restrictions. It cannot be submitted with visits that are reported with a modifier 25. So if you do a procedure and you report your office visit with a modifier 25, you cannot report this code. It cannot be submitted with Medicare wellness visits. That makes sense because it can only be reported with CPT codes 99202 to 99215, not the Medicare wellness visits, which are all G codes. CMS will monitor whether clinicians are avoiding performing preventive services on the same day as office outpatient visits, because if they are avoiding them in order to avoid reporting modifier 25, they can then report G2211, but that would defeat the purpose of ongoing comprehensive care. Now, here's one thing we have been really debating. Most of us think this can be reported if your office is in a hospital or facility-based setting. There are some differences of opinion, so I would be cautious about this, but if you are practicing outpatient medicine, submitting 99202 to 99215 in a hospital-based outpatient setting, I think it's probably worth using the code. It's possible you may get denied. I doubt it, but we have, maybe 75% certainty it's okay. I think it'll get clarified over time. Nothing in the final rule said this, but looking up at the hospital outpatient prospective payment system, it was unclear that it was allowable, but then looking in other sources, it seemed to be okay. Okay. So here's some examples. Primary care clinician, who is the continuing focal point for all healthcare services, may submit G2211 when evaluating the patient for sinus congestion due to cognitive load of the continued responsibility of being the focal point for all needed services for this patient. So this may be a low E&M code for just a sinus congestion, but if you happen to be that primary care doc, and this is the patient that gets continuing service longitudinally from you for all comprehensive care, you may submit it even if the patient comes in just for sinus congestion. Secondly, it may be submitted for a service that is part of ongoing care for a patient's single, serious, or complex condition. So example, an infectious disease doc is managing a patient with HIV over time. That infectious disease doc can use this as well. Can't use it if you're just doing a consult and a follow-up here and there, but if you're actually taking care of the patient over time and you can demonstrate ongoing longitudinal care of the patient, you may submit this code with the E&M code. It is not restricted to specialty. Okay, I'm going to move on. I think that pretty much sums that one up. I'm going to talk about split or shared services. So what is a split or shared service? It means the same thing. So I'm just going to say split services from now on, or shared services. A split visit is an evaluation and management visit in the facility setting that is performed in part by a physician and in part by a non-physician practitioner, such as a nurse practitioner or PA, who are in the same group in accordance with applicable law and regulations, such that the service could be billed by either one of them. Payment is made to the practitioner who performs the substantive portion of the visit. Remember that facility setting means an institutional setting in which a payment for services and supplies furnished incident to a physician are prohibited. So this can only be reported in the facility setting. We'll get into more of that in a bit. So basically, CMS has been, really kind of debating how to define what's the substantive portion of the visit. So for Medicare billing purposes, the substantive portion means more than half of the total time spent by the physician or the non-physician practitioner performing the split visit, or a substantive part of the medical decision-making, except critical care visits don't count because they don't use medical decision-making and use only time. So for them, substantive portion is half the total time. So it can be either half the total time or more than half the total time as a substantive portion, or you can use whoever does the substantive part of medical decision-making. And remember again, and the reason I pointed it out before, because sometimes medical decision-making may yield a higher reimbursement than time, because it may yield a higher code, depending on the complexity of medical decision-making. So follow me on this. The 2024 CPT manual for the purpose of reporting E&M services within the context of team-based care, performance of a substantive part of the medical decision-making requires that the physician or the other qualified health practitioner made or approved the management plan for the number and complexity of problems addressed at the encounter and takes responsibility for that plan with its inherent risk of complications and or morbidity or mortality of patient management. So by doing so, a physician or other qualified healthcare professional, that's either the NP or the PA, has performed 2 of the 3 elements used in the selection of the code level based on medical decision-making. Hope you all get that. And that's why, I showed you that diagram of medical decision-making. I'm assuming that most of you understand medical decision-making because you need to understand it in order to understand this. Note, if the amount and or complexity of data to be reviewed and analyzed is used by the physician or other practitioner to determine the reported code level, assessing an independent historian's narrative and the ordering or review of tests or documents do not have to be personally performed by the physician or other qualified health practitioner because the relevant items would be considered in formulating the management plan. Independent interpretations of tests and discussion of management plan or test interpretation must be personally performed by the physician or the other practitioner if these are used to determine the reported code level by the physician or the other qualified healthcare practitioner. All right, I'm sure everybody's perfectly clear on this. What I do want to show you is the settings in which split visits can be done or not done. And that changed from 2023 to 2024. So now in certain settings, and I've listed them here, and I think the most important settings are facility settings, and that includes inpatient hospital, inpatient or observation in hospital, skilled nursing facility, and you can see that's place of service codes either 21 or 31. The 2024 definition of substantive portion is either more than half the total time or the substantive part of medical decision-making as I described before. Now note, nursing facility, for those of you that practice in a nursing home, you cannot do this. So this is only to be used for patients that are at Part A skilled nursing facility. If they are long-term care in a nursing facility, you cannot do this. And for that matter, you can't do incident 2 either. In an office setting, you cannot use split visits because incident 2 applies. Home residence cannot use, you would have to use incident 2. The emergency department is considered institutional, so you can use more than half the total time, or MDM, medical decision-making, and you can do split visits. Critical care, you can do split visits, but only using more than half the total time. But I think the important thing to understand is that you cannot do split visits in the office and you cannot do split visits in a nursing facility for custodial or long-term care patients. Okay, I know we're going through this really fast, but there's so much that has changed in 2024. I'm checking my watch. I'm going to go through a number of changes. For those of you that work in nursing homes, these are the nursing home codes. The codes haven't changed since last year. There's still 99304 through 306 for newer established nursing facility visits, and 99307 through 310 for subsequent nursing facility care. But if you use total time as your driver for selecting a code, note that for 99306 on the left, the time has been upped to 50 minutes as the requirement for reporting 99306. And for subsequent 99308 has been increased from 15 to 20 minutes for reporting by time. The reason for this is because originally they rounded it wrong. It's a long story, but now they have rounded it correctly. And these are the times based on surveys of physicians. But it's only those two codes that have changed. And because, and this does not change the time necessary for prolonged visits. There is a new code, 99459. That is a CPT code. This is an add-on code. And this is for a pelvic exam with an office or outpatient or a preventive medicine visit. Those are CPT visits. It's a practice-only expense. It has no work RVUs associated with it. And the reason for this is because, generally speaking, if a physician performs a pelvic exam, a clinical staff members usually needs to be in the room with the clinician, and therefore this does add to practice expense, and this has been recognized by CMS. It can be reported with an E&M service or preventive medicine, but only in the non-facility-based office setting, because it's presumed in the facility-based office setting, staff is usually paid by the facility and covered by the facility fee. It is, an RVU of 0.68, which is 22.26 on the Medicare fee schedule, so it's not trivial. But again, this does not go to work RVUs for the physician, it's a practice expense. Here are some E&M guideline revisions, and this is for hospital codes, 99234 to 99236, and this is a little confusing. This is in the CPT book, and it's also CMS has a medical learning matters publication that describes this. But this is to codify CMS rules regarding hospital stays that are less than 8 hours and hospital stays that are more than 8 hours but less than 24 hours. Again, these codes can be used only by the admitting or attending physician or a qualified healthcare professional. But again, it's a little confusing, but if the patient is discharged on the same calendar date as admission or the start of observation and the length of stay is less than 8 hours, you can bill only initial hospital services. If it's 8 or more hours, you can bill the same day admission and discharge. Okay, if the patient is discharged on a different calendar date than the admission or the start of observation, now let's like they come in at 11 p.m. and they're discharged at 6 a.m. So they're there for less than 8 hours, but it's over 2 calendar days. Again, you can apply only the initial hospital services code, but if they're there for 8 or more hours, you can report both the initial hospital services and a discharge day management code. All right, now that we're clear on that, there are some changes in reporting multiple E&M codes on the same day. And a lot of this is just an opportunity to address nuances and questions regarding these issues. And essentially what CMS did was adopt longstanding generally accepted rules and CMS policy and make them more accessible. And one of the things they did, a lot of time, what you read in the CPT manual versus the Medicare manuals tends to contradict each other. And now they're trying, in order to reduce administrative burden, to reconcile the two. So for instance, your hospital discharge code can be reported the same day as an initial nursing facility visit. But that's a big exception to the rule that you can't report generally 2 E&M codes on the same day. A major exception is that CPT codes allow reporting 2 services by the same clinician on the date of another E&M service, example, office outpatient plus initial inpatient, whereas CMS does not. So CPT allows it, CMS does not. So CPT changed the text. So there are now instructions for telling the clinician that only one service may be reported. That is consistent with CMS policy. So let's say you see a patient in your office and then you have to admit them to the hospital on the same day. My recommendation would be to add up the time or the medical decision-making between the two visits and then report the single code that will get you the highest reimbursement, plus prolonged services if necessary. All right. All right, changes in telehealth. All right, now key telehealth flexibilities have been extended through this year by statute. If you remember, at the end of 2022, Congress approved the Consolidated Appropriations Act of 2023, which extended key Medicare telehealth flexibilities. So, for instance, they continued coverage and payment for audio-only telehealth services and telephone E&M services, 99441 through 443, through 2024. They lifted geographic and originating site requirements on Medicare telehealth services again through the end of this year. They extended the ability for federally qualified healthcare centers and RHCs to furnish telehealth services. They also delayed the in-person requirement on Medicare telebehavioral health services until on or after January 1st, 2025. The reason is that this was statutory. Congress passed the law, so CMS cannot extend beyond 2024 without congressional action. So additional flexibilities extended through 2024, direct supervision via the use of two-way audio video communications technology, other than the teaching physician in an Office of Management and Budget defined metropolitan statistical area. This can be used for labs 99211. This is for nursing, not the teaching physician situation. Also, they have extended the removal of frequency limitations through 2024 for subsequent inpatient visit CPT codes as listed. For those of you that work in the nursing home, you may recall that at one point there was a limitation of using telehealth every 14 days that has been temporarily removed through 2024. The same for critical care consultation services. And as you know, these policies were initially suspended during the public health emergency, and now they've been extended. CMS does plan to consider further extensions or changes in future rulemaking. A lot of this depends on utilization, but also on statutory considerations by Congress. The teaching physician rules, including the primary care exception, have returned to pre-public health emergency, other than the remote supervision of a trainee outside a metropolitan statistical area and virtual supervision when the service itself is virtual. I listed the codes that are still reportable by telehealth. These are, of course, 99202 through 99215, office outpatient. These are permanent. However, audio-only interaction cannot meet the requirements of these codes. These have to be audio-visual, and usually you would affix a modifier 95 to indicate that they're being performed by telehealth. Home visits, these are provisional. Or at least the 99341 through 99345. It remains to be seen what happens at the end of the year for the new or initial home visit codes. 99343, by the way, was deleted from CPT, so that doesn't exist anymore. But 99347 through 50 established patient codes for home and residence visits. Two of them, 4748, are permanent. 49 and 50 provisional, but for this year, all of these codes are reportable by telehealth. But again, audio only cannot be used to report these codes. Remember to use the correct place of service codes. So place of service 10 is for services delivered to the patient's home, broadly defined, and pays the full non-facility allowance, the same as an office visit. Whereas POS2, which is telehealth provided other than in a patient's home, is the older telehealth service from a facility to a remote healthcare site and is paid at the facility rate, which is likely going to be lower. So remember to use the correct code. I would advise not to use virtual check-in codes if any of you are using these at all when you're allowed to use the telephone visits or the office visit telehealth codes, because virtual check-in codes don't pay as much. And by the way, occupational physical therapists and speech language pathologists and audiologists may do telehealth starting this year. All right, we're going to talk a little bit about prolonged services. Again, I know we're rushing through a lot of material, but there's a lot of changes to go through.